Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Hello, welcome into another episode of the Medical Collective. Finally, we have Dr. Dan back. If y'all don't remember Dr. Dan, one of our amazing co-hosts, ER, and he does so much more than being an ER physician. But today is an important conversation. Had to have him in for this. If you do not remember Dr. Dan, make sure that you do follow him on all his socials, okay? Now, we've talked about the emergency room a lot, Dr. Dan, but today I want to talk about something people don't know a lot about you. You talk about a little bit, but not much, and that's about that you served in the military and you were on the health task force during the Obama administration. So, national security, very important topic. When people hear national security, I know I think about military, terrorism, cybersecurity, intelligence, but we don't think about vaccination rates. We don't think about hospital beds, right? Emergency departments, public health, disease surveillance, epidemiology, and we should. Because whether the threat is naturally occurring pandemic, contaminated food sources like we're dealing with right now with cyclospore and other things, a chemical exposure, a cyber attack on a hospital system, many of the systems that we depend on exactly are the ones that we have to use every single day. So let's start there, Dr. Dan. When you hear the words health security, what does that actually mean to you, especially having seen healthcare through emergency medicine and your military experience?
Yeah, thanks for having me, Dr. Keisha. When I think of, public health, health security, it's really talking about the things that we actually do to prevent, prepare for, interdict, stop, and really try to prevent the diseases from having an impact, a negative impact on people. And actually trying to turn that around. So all those steps, they're pretty much four main stages. But when you look at the big picture, it's what can we do? What's the government doing? What are the agencies doing to prevent and prepare people? You have to empower people. You have to give them information, show them what to do. This is what you do in an emergency. What are they doing in the background? They're investigating cases. They're making sure they're worried about the things that everyday citizens don't have to worry about. So those are the steps: preparing, preventing, thinking about how do we respond to, and putting the money to work to help better the lives for people. So it's from a health standpoint, what those diseases are that we can prevent, be it acute things, public health, bioterrorism, any number of things. It covers a big gamut of things.
So when does a healthcare problem become a national security problem?
Well, it's when it starts to affect the critical infrastructures. So what are those? That's like the hospitals, the roadways that we use to get to work and do our regular commerce, the water, the things we need for sustenance to be able to do our everyday thing. So access to power, electricity, all the things that we need, those are all part of our critical infrastructure. Without it, we can't survive. We can't do our activities of daily living. We can't be as human as we would like to be. We're stuck. So that's what those things try to fortify and make sure those things are protected so they're not attacked. And basically, we can go on with our lives.
I always use the analogy about the road. Once a road is put together, a lot of us assume that we can drive on it and that's it. They don't know behind the scenes how much is going into making sure, right, there's not a breakdown, when they need to do repair, all of those things. And I think I kind of can equate that to what you're talking about. So I appreciate that. And also there was recently, I don't know if you know, that there was an outbreak of flu within some Air Force training, and one person actually unalived. So does that also sometimes become a problem when we think about that? Because everyone's required, right, when they're coming into the military to take the immunizations unless they have a reason. And because the rules changed under Hegseth, they decided to make it voluntary. And these new trainees had flu. Many got flu and one unalived.
Yeah, so I think one of the impacts of being prepared, and we call it having your soldiers being ready, or what we call readiness, and that's actually affects the power, your force multipliers. These are the individual soldiers all together. With them being at full health, full capacity, they can do their job. We can win the war, or win the battle in that case, or accomplish a mission. So if they're not immunized, or they don't have proper health care, dental care, any number of things, those affect their ability to do their job. And if you can't execute on your job, you lose the battle. And that's why it's important. And leaders have to make sure that their soldiers, that's what I had to do. I had over 800 some soldiers in my battalion. And then the whole group, it was almost 3,000 that I was responsible for as an infantry guy. And it is important to make sure you're leading by example, as we say, leading from the front. But it's also important that we are able to protect them as best as we can, so that they're able to execute and do their job without anything affecting that process. So yeah, he should be one to be supportive of that. But I don't know what's going on with this administration, put it that way.
Yeah, I'm with you. You mentioned like the chain of people within the organization, right, within the military. And I think each link has to be strong within its own, but there's also like a chain of command, right? And I think in healthcare, we don't forget about that. Maybe there's someone gets sick. There's a respiratory infection. There's diarrhea. And then the ER may have never seen this before. And so now all of a sudden you're seeing more of it, and you start to see maybe what is an uptake, and then you have to look back. So it goes from the patient to the ER clinic, then the laboratory has to test, and then we have to go do surveillance, and then there's a pattern, and then there's a public health response. From your side in the military and the ER, at what point do you stop thinking, okay, this is one sick patient within itself, and this is more of a public health issue?
I think it's when those resources start to get overwhelmed, what we call a disaster. And there could be a disaster of 4 or a disaster of 1,000. Just depends on what those resources are. What do you have available? So when I say a disaster of 4, an incident of smallpox, 1 or 2 cases of that for something that's been eradicated, that's a public health security. That's a national emergency. It's not only an infectious disease that spreads rapidly, but it has an impact, can lead to death, and it had been eradicated. And why is it out? That makes you ask the question, how did that get out? So then you open a different can of worms. So that's one. Then you could have a disaster based on the number of resources that you have. Even I'll give an example. In the emergency department, it could be a disaster if you have 2 nurses working, 1 doctor, and there's over 50 patients. And y'all can't assess them. All the staff are sick with, I don't know, diarrhea. Just throw those things out there. Those are realities, right, in certain places. So that's a disaster. That's the public health security in that setting, in that local area. But when it becomes national, to your point, where it's impacting other healthcare systems, they don't have resources. We need to transfer this patient. We can't get them anywhere because, God forbid, bomb went off on the roads and they can't transport that patient. Now we have to take them by air where the weather is not good. There's so many different factors that you have to put into the matrix of figuring out how you define a disaster. But the one thing I would say is every disaster is local. So you have to look at what's happening in that vicinity and what resources they can bring to bear. And then that's how you start to address how you can propagate that type of response.
That's a great answer. So if you start to see what you said, the rule of 4, or something that should have been eradicated, now you're seeing cases of it, who gets called first?
I mean, it should be CDC, the agency that's responsible for it. But we know all about what's going on over there. So that's a different story. But I mean, they'll still be called, notified. How they execute based on their leadership, that's a different story. But yeah, and the local Department of Health, as I said, disasters are local, so they will come to bear because they're going to be the first people on the ground. The citizens there, the doctors on the ground, the nurses on the ground, and they have to then push it up the chain and say, hey, state, we see something weird going on. State has to go to the feds. Hey, we see something weird going on. So that's kind of how that information gets propagated. In a system that really works, or that used to work really well, we have all these little alarm bells and little triggers or warnings that we're doing, testing the water, looking at the cases, mulling through data, so we can pick up those signals before it spreads or even before it becomes a major emergency. But given the cutting of fundings, the misappropriation of priorities, all those things, only God can be with us.
I know. But we have to be with you because as the ER doctor, you all sometimes are going to be the entry point of these uptake of outbreaks. And measles is one of them. And cyclospora is another one. How much are you as an ER doctor interacting with the infection prevention or the health department?
We definitely do. Fortunately, we have someone who's dedicated to sharing that information with the Department of Health. So let's say we see a case of measles, and she had one last week. And then we notify our local epidemiologists within our system in the hospital, our infection control people, basically. And they take the case. They say, hey, these are the protocols that we're doing. They push that up to the state. And Department of Health comes and they do the epidemiologic, or AKA the investigation, so to speak, where they go to the house, look at the situation, who's all involved, where did they go, as we do contact tracing and all that information, and what other things do they need at that time. Do they need certain medications? We give them the dose. Do we need to prophylax, meaning treat other family members or relatives within that circle? All those types of things get discussed and ironed out. So we have a system. We know how to do it. It's just, are we willing to do it? Are we putting money towards doing it? Is the state funded? Is the federal funding the states? Is the federal are the federal agencies still funded or functional or have a mandate to continue to do their work? So that's all. It's the wherewithal to do the things and leadership.
Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. Yeah, it requires leadership and the silent systems that are working. I kind of think about it as like a relay where each person is handing off the baton. But right now we are having this snail mail system where we may not have somebody there. They're not available. They've lost their job. And so parts of the relay race are being broken. And when it comes to something like this, it's going to be detrimental to many people. And one facet of it, Dr. Dan, is the laboratory perspective. The ER can always recognize a syndrome, but when it comes to diarrhea, explosive diarrhea, they're going to need to do testing. And I've spoken in another episode about the testing and sometimes the nuance to just ordering a fecal test will skip cyclospora. But that's why it's important to know that there's an outbreak so they know what to test for specifically when they send it off to the lab. But sometimes it requires a public health lab or reference testing, and that's data. And the data is important to be able to prepare for things like that. It's not just one hospital anymore, it's a whole system, and it's part of the preparedness. So what happens when a disease is already overusing the system? For example, measles. I've been tracking measles for a lot. I know that we're over 2,400 cases. I know that at the end of this month, actually, they should be reviewing our elimination status here in the United States of America. And Canada is number one, you all, for losing their immunization, their elimination status for measles. We may be number 3. So in the United States, our MMR coverage fell from 95% of children immunized. Now, about 286,000 kindergartners are at risk this school year because they're not immunized. By July 2026, the United States had already reported the 2,100 cases, as I mentioned, with 31 new in 2026, and it keeps rising. We're seeing outbreaks in different areas. 93% of those confirmed were outbreak associated. So it's happening in the United States of America, not travel related. 92% of the cases were in people who were unvaccinated or unknown vaccinated status, right? And now the vaccination rates are going down. Here's my question. If we're already spending people, lab capacity, mind you, $50,000 it can cost per patient with measles. So money, resources, isolation, hospital resources, public health, manpower to go back and contact trace. What does this do to our reserve capacity if something else comes that we're not expecting?
Yeah, that's the scenario. So these are what if scenarios. Don't want to be an alarmist, but these are what we think about in public health, and this is what people think about in general who are in the field. Regular citizens, they need to worry about other things. This shouldn't be their burden, but it becomes their burden because they're part of the problem also, because they don't trust as much anymore. And the system has also violated the trust. So it's kind of figuring out that message is broken. So if we have another incident and another incident, at some point, you get to the point where capacity is overrun. And I pray we don't get to that point. And that has an impact because it's a life at stake. And depending on the disease process, and who it affects, its mortality rate, that will determine when people wake up, unfortunately, and when policy wakes up. I'm hoping that new leadership will start to put that as a priority, because even if we do the numbers, because they like to worry about numbers. So if we start to talk about our GDP and our budgeting for the global economy, for the U.S. economy, and see how much it costs, that's the analysis that needs to be made, and the argument, how much it costs per patient to prevent a case of measles, how much it costs per patient to treat a patient with measles, how much it costs in addition to life that could be lost for us trying to rip all the systems out of place and then have all these cases and manage them. The burden on the emergency department. So now they're coming to the emergency department. Other people that could be seen for other things, heart attacks and other things, aren't being seen because this patient is prioritized and now has this complication. If they become debilitated, now they have to go through the health system to get rehab and all these things. These are all costs. Time to the family, time away from family, psychological stress on the family. I could name everything. It's a cascade, literally a concatenation of different events that basically go in series and lock up. So it's just kind of straight like that, linear. And some are even, they bifurcate, meaning they go not only linear, so it goes this way, it goes that way, and all of that. Those effects kind of multiply together and have a even worse impact. So, yeah.
I agree. We have to have our resources, and that includes manpower. And I want to use a couple of data points. As of August 2026, the CDC has experienced more than 3,000 staff departures. They have had layoffs, resignations, restructuring. There are also reports of funded CDC programs that technically still exist, like the Cyclospora Task Force, which actually was started a while ago, is still there, but we don't know how functional it is. State public health laboratories as well have recently had to absorb additional work after CDC has paused reference testing. So imagine the amount of work that the laboratory is doing. So here's what I want to understand. Can you dismantle, and I know your answer, But can you dismantle expertise and then simply turn it back on when there's an emergency? I think this is what people need to understand.
It's just a switch. Just flip it on.
Oh, can you guys come back?
Yeah. Hey, can you guys come back? Nah, that's not how people feel. People feel like F you, honestly. They're not coming back. They're coming back under the right leadership. When you give people guidance and I want to follow somebody who's leading me to the right path, who's having an impact on the public, who really cares about people. That's why we went into the profession. So yeah, nobody wants to come back to that. So I can only respond to an authority that doesn't see the vision, the bigger picture, the selfish. So no, people aren't trying to come back to that. It's like you leave a job because you were treated bad, but it's not even the treatment bad. That's one part, but the impact that you used to, the love and the passion that you have for the job was being able to help people and citizens. And I think several federal employees feel that way, even state employees. These people, they love what they do. That's why they took the job. And they've been lifers. And then you come and uproot them and go through that whole process of being scrutinized. So people are like, nah, I'll go do something else. And I'm not mad at them. They can only try and do what they need to do to take care of their own families and do their own responsibilities. So it's hard. So when you dismantle public health, to your point, of course, I was speaking tongue in cheek. No, it's hard to rebuild. It's not that it can't be, but you got to put those back in place. But there's been damage done. We saw the pink elephant. You can't say you didn't see it. So there's damage done. You've removed support by literally making this everything's a hoax, everything's a story. It's government out to get you. This causes autism. All that. So you eat at what you're supposed to be building. So people don't have trust. And when there's doubt, people are going to make their own decisions and they take it into their own hands. But unfortunately, they're not informed as well. They're misinformed because they get misinformation and disinformation.
Right. I agree. The most important component is people. And we recently had an anniversary of the attack on the CDC, and a lot of people are still traumatized by it in many different ways. And I think we have to be able to acknowledge what people are going through in these positions. The laboratory, though, is the same thing as far as a resource. You can't hand somebody a test kit if you're not doing the validation for it. During C-19, it took a while to validate the test to do it. You have to be prepared. You have to have competency, the correct instruments, all of these things. And this takes years to build, everybody, years to build. One last thing is the infrastructure we don't see, which are the supplies, the things that we need. The hospital preparedness program has $240 million available for July 26 through 2027 budget to support healthcare preparedness. And the Strategic National Stockpile maintains countermeasures and supplies for these emergencies. But having the supplies is not the same as having them available at the bedside, right? So what exactly are some of the things that need to be ready in the case of an emergency, like ventilators, meds, communication systems, Dr. Dan?
He's speaking my language. So, as you know, I was the principal author of a document for the Academy of Pediatrics and testified before Congress on this stuff about the U.S. not being prepared and what those medical countermeasures are that we need. And when we addressed those, we found out that there were some that were lacking, especially for those extreme of ages, the elderly and then the children. The 18 to 50 age range, that's typically the soldier range. We had those supplies. And even with that, there was still some gaps. We tried to close that gap, and that was important. And they made some efforts, but then a regime came in and started dismantling what we were doing. Weren't prioritizing certain things. So everything for different types of threats we thought about for what we used to call sea burning, but now it's sea burn. So it's chemical. C is for the chemical, B is for the biological, R is for radiological, N is for nuclear, and then there used to be the E. They've taken that off, which is explosives. So these different types of threats, and then they had different types of agents that you would worry about. Anthrax, these are category A agents, category B, and all these types of things. Not to bore you to death, but the point is there are different things that can threaten us. As we see, and we get certain little viruses, they threaten us when we get sick. So then we have the new things. And then don't let me even go into the whole thing about regulating AI and all things that we worry about that can also affect our public health. These deepfake issues with regards to a public health emergency that could be feigned or faked, and people's credentials being taken. We have a lot of problems. So I think I got lost in discussion, but the point is that, yeah, we need supplies, and just having the supplies is not it. Knowing how to use the supplies, how to get them to the end user, that's the doctors, nurses on the front lines, and ultimate end user, the patient who needs the medicine. How do we get it in them? All those things have to be coordinated, practiced, and have to be shifted. And that's why you can't be distracted with war somewhere else and this going on over there, and you're not focused on the economy. People need food on their tables. These types of things that are important for every day-to-day person, but also prepares us for the future catastrophes that will occur. It's not that they won't. But how are we fortified? Will we be able to sustain, to hold up? Will the cavalry come and rescue us? Can you buy some time? Can you hold your own? Can the state help you for a little bit? Can you do something yourself? Those are the things that we really need to start asking.
I love that. Also when you were talking about resources, and if something were to happen, if two states are needing resources at the same time, right, two natural disasters, as we're dealing with flooding, that's going to take away from other things that we need. And when it comes to national security, if somebody deliberately, now on top of a natural disaster, if somebody deliberately exploits a weakness, whether it's a chemical exposure, a biological attack, a cyber attack, or misinformation, which to me is one of the most dangerous ones, when do you think about vulnerability and weakening routine public health infrastructure and how that makes us more vulnerable to an intentional attack? I think this is the part where we already are dealing with a lot of attacks on ourselves from Mother Nature, and we are being our worst enemy. But what about when we have something else from outside coming in this state that we're in?
Yeah, so you've already been primed for weakness, I would say. So you start to chip away at the support. It's like, use some analogies. It's like a chair, and you start hitting it with a saw or an axe. Gradually, over time, it's not a really sharp axe, but it still is an axe. Gradually, over time, as you eat away at it, it erodes. And then when something real, a heavy load or weight sits on that chair, it's going to buckle, and it will probably crack and break. And that's what you worry about, because everything kind of stacks up, and it just continues to build up and eat away at the support, the foundation, so to speak, the day-to-day preparedness.
Yeah, the day-to-day preparedness, that's the theme of today. All of the systems have to work and have to be in place before, from the emergency room to the laboratory to the epidemiologist to vaccination, hospital preparedness, strategic national stockpile, all of these things. So in conclusion, Dr. Dan, if you were advising national leadership today, you are in charge. What are the three pieces of American health security infrastructure you would protect first?
I think the most important is being able to ensure that people have access to good food, actually, and nutrition. I think that's important part of it, because if all of those are secure, that's what people worry about, what they're going to feed their family, put on their table. How am I going to feed my kids and my family? I think that's an important part. I think the education around it, around the potential threats and what we're doing, so visibility, communication is important. And most importantly, building and regaining trust. Very important, because once you know that I got your back and I know you got my back, I'm not going to worry about those things. I'm going to do my part to be supportive of the bigger picture, knowing that you're also looking out for me. So those would be the most important things. And when I say building trust, like that can be a long laundry list. Building trust is having the conversation. Yeah, we screwed up. This is where we're fixing this. We screwed up by removing all of these vaccine programs. We're reinstituting this. We are listening to the policymakers, specifically from the medical community, i.e. AAP, ACEP, ACS, all the different medical organizations, AMA, that are talking about the importance of public health, the American Public Health Association. So I think those are the things. Bring people who actually care and who have built the system back. Get feedback from people. Communicate clearly. Own your own lane, own your own shit. So wherever things we did wrong, own up to it and fix it. Have the real candid conversation about what it is, and let's move on with things. And then make sure people are sustained, jobs, financial support, systems that were in place before. Why are we ripping things down? We want to be able to support families who can't or don't have access. Insurance, let them feel comfortable. Preventative diseases, good, healthy food, all the stuff, the vitamins, everything. It's all literally, we need to focus on prevention, and we need to focus on empowerment and communication. I think those are the things, and all that circled with a bow of trust.
Well said. Well said. Thank you, Dr. Dan, for being here. And everybody, till next time, enjoy.
Thank you.
Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.